Good afternoon. I stand here to defend the case against surgery. Live debates are always a bit challenging, and I would say it's a bit more difficult when the opposing opinion is represented by someone who is taller, better looking, and speaks English better than I do. Okay? But still, luckily, I have the biologically sound statement in my hands. Let's see. So these are my grant scholarships, etc. No conflict of interest associated with this presentation. As Dr. Tomasetti showed yesterday, we kind of all know and believe that endometriosis is somewhat associated with infertility. But the causal link is missing. We don't know by which mechanism, except for bilateral tubal blockage, endometriosis causes infertility. So any debate like this, when we discuss effect of a surgical treatment, that reminds me of this famous saying, and you feel free to replace the word hammer with the word scalpel. Okay? And luckily, it's not the only thing we have. We also have other effective treatment options for endometriosis-associated infertility, such as assisted reproductive technologies. Let's see what happens in real life. Okay, so how do we encounter endometriosis in infertility practice? So what happens is, infertile couple presents, we thoroughly assess them with a detailed medical history, like full physical exam, and the indispensable transvaginal ultrasound. We evaluate ovarian reserve, tubal patency, the male factor. Endometriosis may become relevant in 4 scenarios. We may end up with the diagnosis of so-called unexplained infertility, which would obviously include some case of peritoneal endometriosis, or transvaginal ultrasound can show an endometrioma, or either pelvic exam, or if you're as good as with transvaginal ultrasound as Dr. Exokustos is, transvaginal ultrasound can suggest presence of infiltrating endometriosis, or finally, the patient may have already been diagnosed with endometriosis in advance. So, if I am to offer surgical treatment to this lady with one of these conditions, a proper informed consent procedure would include discussing with her the anticipated benefits of surgery, ideally in terms of improved live birth rates. I also have to mention her the risks, not only the regular surgical risks, but also things like ovarian reserve. And finally, I have to inform her of legitimate alternatives, which does not only include spontaneous pregnancy rate, but assisted reproductive technologies. Let's see how these 3 items interplay in these different scenarios. So this is the most recent, starting with peritoneal endometriosis, i.e. unexplained infertility, because you can't diagnose it without a laparoscopy. So peritoneal endometriosis, this is the most recent Cochrane review. And the Egyptian study mentioned by Dr. Becker and the famous Canadian study, odds of a live birth is increased by almost 2-fold. But what happened to the Italian study? As mentioned, this is only an abstract. There's no critical appraisal. The Italian study was excluded because some women were allowed to use GnRH agonists at the discretion of their physician after surgery. But if this proportion is not differential between the 2 treatment arms, then the results wouldn't be biased. So if, as in the former Cochrane review, I include these 2 studies and properly assess them with a random effects model due to high heterogeneity, then surgery is not beneficial. Or, you can say, why don't we include all 3? Okay. Again, surgery is not beneficial. I can hear you asking what happened to the Navruzi trial. Now, obviously, treatment allocation by social security number breaches the principle of allocation concealment, which is the single most important step in preventing selection bias. So that will be never included in any systematic review. But my point is simple. There is controversy regarding the effectiveness of surgical treatment of peritoneal endometriosis in improving spontaneous pregnancy. Okay? What our society recommends is just shown, yes, if we happen to do laparoscopic surgery, diagnostic laparoscopy or laparoscopy for any reason, and we identify peritoneal endometriosis, destruction of these lesions makes sense. And what this means is, I have to treat peritoneal endometriosis in 12 women to achieve 1 additional pregnancy. Okay? But the real number needed to treat depends on the underlying prevalence of endometriosis among my patients with unexplained infertility. 50% is based on 1 study, and I think it's an overestimate. So in this case, the number needed to treat would be somewhere between 17 to 24. If it is 30%, as suggested in most studies, number needed to treat, I would have to do laparoscopy to 25 women to achieve one additional pregnancy in the next year or two. And if it is, in your own population as low as 10%, then the number goes sky high. And let me remind you, these are only point estimates based on 2 or 3 studies. Look at the confidence intervals, the upper boundaries. The number needed to treat, is equally likely to be this high, right? So if you're not still convinced against doing diagnostic laparoscopy to identify peritoneal endometriosis, let me remind you 2 more facts. We know from Chris Sutton's studies, which we can't do anymore, doing a real laparoscopy in 6 months to observe the natural history of endometriosis, peritoneal endometriosis. What he showed was in 42% of women, the disease regresses spontaneously. So almost half of your patients will become to the same status even if you don't do any surgery at all, right? So probably it's futile. And secondly, I'm not quoting any numbers, but I just want to remind you, regardless of what you do inside the abdomen, the vast majority of laparoscopic complications happen during entry to the abdomen with your first trocars, okay? So it's not totally safe. So my verdict for peritoneal endometriosis, benefit, if controversial, at best marginal, okay? Risk, same as in laparoscopy, and there's also a risk of recurrence like 30%. And cost depends on the system, but whatever the cost is, whatever the risk is, how small they are still, to me, unacceptably high for a procedure that is bound to be futile most of the time. Now, proceeding to the second scenario, transvaginal ultrasound shows an endometrioma in an infertile woman. Okay, so what could be possible benefits of surgery? To diagnose or rule out malignancy, as shown before today or yesterday, transvaginal ultrasound combined with patient characteristics such as age, we have a pretty high negative predictive value for ruling out malignancy in premenopausal women, especially when combined with new markers like human epididymal antigen 4. The negative predictive value is pretty high, so ruling out malignancy, of course, decision has to be individualized, but would very rarely be an indication in such patients. So, another proposed benefit. Can I treat anovulation in these women with endometrioma? Let's see. This is a great study from Italy. What they did is they observed over 200 women with unilateral endometriomas who were not necessarily infertile, okay, and had a normal male partner for over 6 cycles. They did transvaginal folliculograms for over 6 cycles to assess from which side, from which ovary ovulation occurred. And as you see, regardless of the side of endometrioma, the chance of ovulation was exactly the same from the affected gonad with endometrioma versus the contralateral gonad. And this wasn't affected by the number of cysts or the size of the cyst or the presence of other findings suggesting deep infiltrative endometriosis. So these women are ovulatory already. I'm not treating anovulation. So no indication here. But can we claim that we are improving these people's chance of spontaneous pregnancy? How strong is the literature? Let's see. As far as I know, there's no randomized controlled trial, and hardly there's any controlled trial. Okay? So people, world-renowned surgeons, such as James Daniel, with whom I had the chance to work with when I was a medical student, Crosignani, Jacques Donnet, Chris Sutton, Mauro Busacca, Alborzi, Luigi Fedele, Paolo Vercellini, all great surgeons, present their uncontrolled results. I operated on this woman with endometrioma, and over an undetermined time period, 50% got pregnant. Is this evidence? This is the best available evidence, okay? But is it really robust? Firstly, I got this from a commentary by Paolo Vercellini. We do not even know if these women were infertile in the first place. Secondly, did I publish my results? Did you publish your results? Are we as competent as Paolo Vercellini, Jacques Donnet, and all these people? We have to be realistic. We don't know how complete the follow-up is. When you read these studies in detail, there's a lot of missing people. Okay? And most importantly, this is uncontrolled data. And the most important question is, what is the pregnancy rate without surgery? What's my benchmark to claim that surgery improves pregnancy rates? Let's look back at the same study that I showed. They followed up 244 women with unilateral endometriomas. And during this follow-up, 105 of these women got pregnant spontaneously with their endometriomas in place. Okay? And furthermore, when they compared the chance of achieving a pregnancy from an ovulation from the affected gonad versus the other gonad, the chance of pregnancy is the same. Endometrioma doesn't seem to affect the oocyte based on this study. Okay, so I'm not really convinced. And another recent study, this is a retrospective analysis by Rafi et al. What they did is they screened their records in their hospital for over 10 years and identified women who underwent an endometrioma excision and compared the pregnancy rate among these women before surgery versus after surgery. I mean, yeah, you can say that endometrioma excision does not hamper their fertility, but in other words, you can also say it doesn't improve their fertility. What you cannot say based on this data, endometrioma surgery does not improve fertility at all. Okay, so it seems unlikely, to be fair. And is it legitimate to claim endometrioma excision improves IVF success if the woman is bound to undergo ART for any other indication anyways? You have seen this meta-analysis over and over today, so I'm just skipping it fast. What it shows is compared to women without an endometrioma, women with endometrioma have the same chance of pregnancy and live birth. And women who underwent an endometrioma excision compared to women who had their endometriomas in place have the same pregnancy and live birth rates, so there's no benefit of surgery in this context. So I don't see a benefit here. But should I do something based on that it's not harmful? Then there's so many things that we can do to patients. But let's see, is it really not harmful? The most important thing is decrease in ovarian reserve, just to save time. You've seen this before earlier in the morning. Two meta-analyses unequivocally show serum AMH levels decline after surgery. And we have shown the decline is persistent and there's no rebound. So we irreversibly damage ovarian reserve somehow. And even though our dear friend Ludovico Musi proposed that antral follicle count wasn't changed, we published a 1,500-word letter with two figures, reanalyzing the data in the literature. Even the corrected figures for AMH are significantly decreased after surgery. And what Ludovico Musi did in his paper, even for women with unilateral endometriomas, they compared total antral follicle count in both ovaries. Inclusion of the healthy gonad obviously dilutes the effect of surgery on the diseased gonad. And when you compare the data, which reported only the antral follicle count in the operated on ovary before and after surgery, even though the sample size is small, you see there's a strong tendency to decline. So I don't think the harm on ovarian reserve is questionable. Okay? And the complication of surgery, rarely in case of bilateral endometriomas, it is rare, but there's the risk of premature ovarian failure. And endometrioma is not always alone. If you also diagnose, infiltrating endometriosis and start treating it surgically as well, then you start looking at risks such as fistula. Okay, is it worth it? I don't know. And finally, the other risk is recurrence. What is the rate of recurrence after endometrioma excision? How long does your treatment last? Okay, I think the best place where we can find the answer to this question is these three randomized controlled trials where the authors investigated the rate of recurrence, the effect of oral contraceptives on the rate of recurrence after endometrioma excision. Our answer lies in the control group who received no medical treatment after surgery. As these women are contemplating pregnancy, we can't put them on the pill, and even as short as 6 months, 1 out of 5 have an endometrioma in place. So is your surgery really effective in any way in improving her fertility? It will be pretty embarrassing when the woman comes back to the office, when you diagnose her with an endometrioma again. So I think harm outweighs the benefits in terms of promoting fertility. Finally, deep infiltrating endometriosis. Is surgical treatment of deep infiltrating endometriosis fertility promoting? Again, there's no randomized controlled trials, and that's the best evidence you can get. That's the only controlled study that I could find. Okay? This is from, again, a very well-experienced clinic, and this from Paolo Vercellini. What he did here is excluded women over 38, excluded women with endometriomas to isolate the effect of infiltrating endometriosis. All women were systematically counseled before surgery. They were all diagnosed with rectovaginal endometriosis. Some of them opted for surgery, some of them did not, best evidence. And all surgeries were done by Dr. Vercellini himself. And this is the cumulative live birth rates. The dashed line shows the ones who underwent surgery. So surgery does not seem to improve spontaneous pregnancy rates in this context either. And let me show you in my last 3 slides, let's say, the most recent publication. This is coming from the Strasbourg group. This is a case series by Arnaud Wattier, who is one of the most experienced endometriosis surgeons worldwide. Okay, what they did is this time they retrospectively collected data from 138 women who was diagnosed with endometriosis, severe endometriosis plus infertility. They operated on these women radically, and even in Arnaud Wattier's hands. Okay, so the operation takes on average 3 hours. Okay, look at the figures. They had to do a partial cystectomy in 1 out of 5. Almost half of them underwent bowel resection. Endometriosis surgery, severe endometriosis surgery, is not a child's play. Actually, you see the procedures, and look at, even in their hands, the rate of incomplete surgery is 10%. Okay, so that depends. And 73 of women were lost to follow-up. From an epidemiological standpoint, we should assume that they are not pregnant, but that's not the point. Still, let's look at the remaining 115. What happened? Cumulative pregnancy rate is 54%. So sounds good. I mean, you were just told that the pregnancy rate expectation is 0% in these patients. Okay, but let's see the detail. Half of these pregnancies are eventually with assisted reproductive technologies anyways. Okay, if surgery does not improve the outcome of ART, these women might have undergone ART before surgery, and that would have saved them resections, etc., unless they had other indications for surgery. And now, obviously people are not dying right and left, but here's what's happening: 14% risk of fistula. Okay, I mean, I'm not talking about some pain. I'm not talking about some drop in hemoglobin. Okay, recurrence rate almost 20%. So I really doubt whether this is an effective treatment of infertility, whereas we have other alternative options. And doing an ART cycle does not preclude spontaneous pregnancy afterwards. I mean, they can keep trying. So here are my conclusions. For peritoneal endometriosis, surgery is most likely futile most of the time. Endometrioma, I mean, obviously based on this data, it's not first line. And deep infiltrating endometriosis, it is, something dangerous sometimes. And there's no solid evidence suggesting it is beneficial for promoting fertility, unless you're doing in a context of a properly designed study, or with great experience, stay away unless otherwise indicated. So thank you for your time.